I'm Dr. Larry Dean, the director of the UW-Madison Regional Heart Center. I'd like to welcome all of you to UW-Madison Regional Heart Center Grand Rounds today. Our topic today is atrial fibrillation, a surgical perspective. Our presenter is Dr. Gabriel Aldea. He's professor of cardiothoracic surgery in the Division of Cardiothoracic Surgery at the University of Washington School of Medicine and is chief of adult cardiac surgery at UW Medical Center. Dr. Aldea.
Thank you. This morning I would like to share with you our excitement and enthusiasm about a very dramatic improvement in cardiac surgery, and that is the evolution and maturation of a surgical approach to atrial fibrillation. For the non-physicians in the audience, I'd like to review with you what atrial fibrillation is, and that is a rhythm that's characterized by an irregular and chaotic activity in the upper chambers of the heart, or the atria. It is characterized by a very rapid ventricular response, and this ineffective atrial contraction results in clot formation and in a decrease in the efficiency of the heart and heart function. Over time, this progressive changes occur in the atria, and this causes secondary changes in the anatomy and physiology of the heart that makes this condition harder to treat. The incidence of atrial fibrillation is dramatically affected by age. So patients younger than age 50, the incidence is quite low. It's under 1%. And as we see, the incidence increases very dramatically, whereas patients over the age of 75 and 80 have a 10% incidence of this condition. So because of the aging patient population, we expect this condition to reach epidemic proportions, and the incidence will increase by 2.5-fold from the current 2 million people that are seen in the United States every year to about 5.6 million in the year 2050. The causes of atrial fibrillation are numerous. They're not so much causes, but rather associations, and those are the association with hypertensive heart disease, structural heart disease, that is coronary and valvular disease, thyroid conditions, inflammation of the lining of the heart, or pericarditis, cardiac tumors such as atrial myxoma, cardiomyopathy, and we see this condition commonly after cardiac surgery. But in 40% of patients with these conditions, there are no other associated heart conditions. There are three main issues related to atrial fibrillation. Those include clot formation, which leads to embolization of stroke. So when there is ineffective contraction in the upper chamber of the heart, the left atrium, frequently there can be some clot that forms in this appendage or outpocketing of the left atrium. And this clot can fracture and then cause embolization and stroke. So we see that, in fact, in all patients who have atrial fibrillation, there's a 2 to 10% incidence of stroke per year, and 25% of all strokes are associated with atrial fibrillation. And the consequences of a stroke are seen in the lower CAT scan of the head that show a devastating neurological event. The second clinical issue that we see is rapid rhythm, and this can lead to secondary abnormalities of the heart, which are called myopathy or cardiac dilatation. And finally, the irregularity in rhythm or the loss of synchrony can cause congestive heart failure. So each one of those abnormalities has to have some specific medical management to it. Anticoagulation is very important to try to diminish the risk of embolization and stroke. So this is a composite slide showing multiple prospective randomized trials, and we see here that the use of warfarin or Coumadin, an oral anticoagulant, is highly effective in decreasing the incidence of stroke and overall mortality. The reductions are 62% and 26% respectively. However, medication with anticoagulation does not eliminate the incidence of stroke, nor does it diminish completely or eliminate the incidence of mortality. And furthermore, the association there are significant side effects related to anticoagulation, which are severe bleeding that are seen in 1 to 2% of the population per year. And there are some difficulties in administering this medications to all patients with atrial fibrillation. There are some contraindications to anticoagulation, and as we've heard in prior grand rounds, there are some issues of compliance and monitoring, and consequently, as many as 35% of all patients are not adequately anticoagulated. There are specific patient subsets that are particularly at risk for increased stroke, and those are the elderly, patients over the age of 65, patients with diabetes, hypertension, congestive heart failure, prior stroke, or the presence of rheumatic disease, prosthetic valves, or clot by transesophageal echo. And in those patients, the incidence of stroke is increased significantly to as high as 7 to 10% per year. There are several studies to try to assess the advantage or the equivalency or the benefit of treating either rate alone or rhythm control as well. One of the largest such trials is the AFFIRM trial, and this is a very large study that evaluated over 4,000 patients to see whether or not controlling rate alone would be equivalent to controlling rhythm. Of note is that all patients were treated with anticoagulants, but as we see, there is no significant benefit of one therapy or the other, but more dramatically, if we see the secondary endpoints, and those include death, disabling stroke, major bleeds, or cardiac arrest, patients treated with rhythm management did not have an improved survival. So if we could extrapolate it and look at it from a total benefit point of view, as many as 15 to 30% of patients would have a significant complication of death in association with atrial fibrillation despite optimal medical management. The impact of atrial fibrillation or the presence of atrial fibrillation in a patient undergoing CABG is also quite important. The question is whether or not the presence of atrial fibrillation would adversely affect survival. And in fact, this study tried to answer this, and in fact, we know that the presence of preoperative atrial fibrillation significantly worsens survival in patients undergoing CABG. But as I said earlier, there's a significant association with atrial fibrillation with other risk factors that would also adversely affect survival. So this study tries to eliminate these associations and try to more carefully isolate the specific effect of atrial fibrillation alone by a technique called propensity matching. And when we do this, we see that in fact atrial fibrillation, even in patients that are treated with bypass, significantly decreases survival over 10 years by as much as 20%. And the same kind of results are seen in patients undergoing valve surgery. So atrial fibrillation is wrongly assumed to be benign. I've shown you that it's associated with significant morbidity and mortality. Medical therapy is neither benign nor totally effective, and medical therapy has significant side effects. Corrective surgery for structural heart disease does not completely eliminate the risk of atrial fibrillation, and this condition is very frequently undertreated. It is a very costly condition. It costs over $10 billion a year to care for these patients in the United States every year, and as I would show you in a moment, it's very amenable to surgical correction. The goals or the curative goals of a treatment for atrial fibrillation include the restoration of effective atrial contraction and atrial ventricular synchrony, and this will result in improved cardiac function. It's to decrease the risk of a stroke and decrease the need and risk of long-term anticoagulation, and as such, we hope that the cumulative results of all of those things will improve both symptoms and survival. There are multiple possible mechanisms for atrial fibrillation. A common one is the assumption that there are focal triggers, that is, there are specific foci that fire rapidly and irregularly, and typically those are found in the pulmonary veins near the junction of the left atrium. And this is something that was recently demonstrated to be a correct etiology, and we will show you the consequence of that in a moment. Another possibility is that impulses that are fired occur as multiple wavelets which do not extinguish, and those propagate and wander in the atrium, causing random cell contraction. This is more commonly seen in enlarged atria, but requires a significant amount of mass and this is what's called macro reentry, and it requires a certain size for it to occur. And finally, foci can be multifocal rather than from one spot, and those sites can be firing rapidly. They could collide and excite the myocardium at different times and in different directions. But the characteristics of all of these mechanisms make it such that they're amenable to specific interventions. The specific location in the pulmonary veins helps that, and the requirement for macro reentry and critical mass make interventions more likely to succeed. So a new concept had to evolve of how to achieve not only a rate control, but a coordinated contraction of the atria. And that most recent emphasis was pioneered by Dr. Cox, who developed a schema of doing this. Now, traditionally, we think of the sinoatrial conduction as activity originating from sinoatrial node, then being conducted to the AV node, and eventually this is conducted through the His-Purkinje system to the ventricles. I'd like to reorient our attention in a more horizontal plane where the sinoatrial node is projected here, the AV node is projected here, the dark squares represent the inferior and superior vena cava, and this area here is the pulmonary vein. So if we do this in this horizontal plane and we focus our attention, we would see that, again, normal contraction originates with stimulation of the sinoatrial node that is conducted to the AV node. And a concept of creating a maze is to create barriers to these irregular heart rhythms to allow this conduction to occur in a systematic and coordinated fashion. Now, how do we do this? Using cutting and sewing techniques, we would create a maze, which is by a scar, and these are barriers to transmission of ectopic electrical activity. And by doing so, we hope to restore both AV conduction of sinus rhythm and, most importantly, atrial contraction. So looking at the set of incisions that was proposed, and there are several modifications of the maze. This is the maze 3. We see this on the bottom portion, the inferior aspect of the heart. This is the right atrium and the left atrium, the pulmonary veins, the superior and inferior vena cava. These are the atrial appendages, and from the top part of the heart, we see the tricuspid and mitral positions. And you would see that this is a complicated set of incisions that was designed to halt this abnormal electrical activity. Now, the results of the Cox Maze 3 procedure are very important and very dramatic. Remember, these are a very complex set of patients. Over 2/3 of patients needed other associated cardiac procedures other than just a maze procedure, typically mitral valve procedures, tricuspid valve procedures, or bypass operation. 1/4 of those patients had prior strokes, and most of those patients failed medical therapy. Of note is that the operative mortality in these patients was incredibly low. It's only 1.2% in a very high complex patient subset. And the incidence of the restoration of sinus rhythm was remarkable. It was over 98%. Of note also is that the need for long-term antiarrhythmic medication was only 2%, and less than 20% of the patients required long-term anticoagulation. And finally, contractile function was preserved in over 90% of patients. Short-term, about 40% of the patients had brief episodes of atrial fibrillation in the first several months after the surgery. The perioperative stroke rate was quite low. There was about 15% incidence of needing a pacemaker, but the incidence was 0 when the maze procedure was performed alone. And there was some evidence of transient sinus node dysfunction, perhaps unmasked when one takes away the atrial fibrillation. These results, these outstanding results, were maintained at 5 years, where the stroke rates at 5 years were about 1%, and also the maintenance of sinus rhythm and atrial contraction was also maintained with an equal efficacy. So consequently, the cut and sew maze became the gold standard for surgical interventions for atrial fibrillation. However, there were some significant limitations with the cut and sew maze. As you see from multiple incisions, particularly in sick patients with comorbid conditions, there is a significant risk for bleeding during the surgery and requiring of transfusions. The procedures themselves are time-consuming, frequently requiring about an hour to 2 hours of arrested heart time during the surgery to complete all the incisions. Perhaps there was a higher need for pacemakers, and they were very technically difficult. Therefore, very few patients actually received this treatment. An alternative to this was introduced through percutaneous techniques, where instead of cutting and sewing, energy sources were utilized to create surgical lesions. And so, for example, in this particular diagram, a catheter is introduced through the groin, passed across the septum between the right atrium and the left atrium, and is positioned in specific anatomical locations, and lesions are created using alternative energy sources. And in specific patient subsets, this can be very highly effective. So for the surgical advances to catch up with what was required, several things had to happen. One is the development of alternative techniques to cutting and sewing that were safer, created less bleeding, were faster, created thin, non-arrhythmogenic scars. We also had to confirm that the lesions that we created in the heart were transmural, in fact, because if a lesion is not transmural, ectopic activity could be transmitted across this specific lesion. The lesions could be also limited or targeted to decrease the complexity of the operation. And finally, this had to be done in such a way that the operation would remain equally effective but with a lower risk. So several new energy sources were introduced: radiofrequency energy, cryothermal energy or cold, microwave energy, laser energy, and ultrasound. And of those, at the University of Washington, we used two specific energy sources, the radiofrequency and a cryothermal energy. The advantages of the radiofrequency energy and some of the evolution of this technology was to introduce equipment that was similar to equipment the surgeons use all the time. So the energy would be delivered by instruments that are similar to vascular clamps. But even more importantly, not only was the energy delivered in instruments that are familiar to surgeons, but the energy can be delivered to a very small location of the instrument, and therefore by using bipolar energy, the lesions could be created in a very specific spot and not injure adjacent areas. And finally, by using impedance algorithms, one can confirm that the lesion in fact is transmural. So the overall effect would be the creation of a very thin scar that would present itself as a barrier for transmission of electrical signals from one part of the heart to the other. Those limited approaches, it could be possible in simplification of the lesion sets that were proposed by Dr. Cox could be possible in certain conditions. So we know from some research that was done by Dr. Haseguri that in patients with paroxysmal or persistent atrial fibrillation, the pulmonary veins are the main source of ectopy, particularly the superior pulmonary veins. So in those patient populations, it would be simple to isolate the pulmonary veins using this technology of bipolar energy and again extend incision sets connecting the two pulmonary veins and to the left atrial appendage. And finally, very importantly, remove the atrial appendage, which is the source of embolization. And these techniques allow us to achieve success rate in 80 to 90% of patients with paroxysmal or persistent atrial fibrillation. This aspect of the surgery is relatively straightforward and is also very amenable to less invasive approaches. However, life is not all that simple, and sometimes in some conditions, foci for atrial fibrillation can arise outside of the pulmonary veins. And in those situations, we know that isolating the pulmonary veins alone would not be sufficient to eradicate this condition. So in this particular study by Schmidt, 53% of sources of atrial fibrillation arose from the pulmonary vein, but again, 47% of patients had other foci that did not come from the pulmonary vein. And in those patient population and those patient subsets, a more complete or a Cox-Maze procedure and ablation scheme needs to be employed to get equivalent success. So the first set of incisions that is made is introducing bipolar energy to create scars that essentially communicate a line between the superior and inferior vena cava. This incision is then carried, and lesion is carried on medially to the AV groove, and finally over the atrial appendage and on the undersurface of the atrial appendage. The next set of incisions are at the level of the atrial septum. One is to connect this incision set to the pulmonary veins, the other one more immediately to the fossa ovalis, and a very important lesion set is behind the vena cava, the inferior vena cava, and the coronary sinus to prevent some flutter waves from being conducted. And by creating this lesion set, you would see that the only way that signals can be transmitted from the sinoatrial node is toward the AV node. And finally, at the level of the left atrium, we would isolate the left pulmonary veins, and this is typically done with bipolar energy from the outside of the heart, the right pulmonary veins, connecting lesion to the left atrial appendage, a connecting lesion to the between the pulmonary vein sets, and finally an extension of this to the mitral valve itself, the mitral valve annulus. And this particular incision set is quite important to prevent flutter from occurring after this procedure. It's also a very critical location because behind this location is the esophagus and a circumflex coronary artery. The results from, with a modification of radiofrequency maze have been studied and reported recently by Dr. Doty at the Western Thoracic Surgical Association. We see that early on, in the first 3 months after surgery, the cut-sew maze or the standard maze has a higher incidence of sinus rhythm. However, at 6 months, the incidence of sinus rhythm is essentially identical, 90% in both treatment groups. So we can conclude that bipolar radiofrequency is equally effective to cut and sew maze. Practical considerations, however, tell us that atrial fibrillation recurs early in a perioperative period in as much as 50% of all patients. So patients early on need to be treated with antiarrhythmic agents, typically amiodarone, and with Coumadin, an oral anticoagulant. If the patients remain in atrial fibrillation at 6 to 12 weeks, cardioversion can be used to synchronize the heart. And there is a debate of whether or not patients need to be on long-term anticoagulation. Because we excise the atrial appendage, the incidence of stroke is quite low, and so some people argue that regardless of what the status of the atrium is, anticoagulation can be discontinued, that is Coumadin anticoagulation, and the patient can be put on aspirin alone. Others argue that one should do an echocardiogram to make sure that the atria contract well, that there's atrial transport function prior to stopping anticoagulation. So what are the advantages of the surgical approaches to atrial fibrillation? They're direct. We can see the anatomy and we can avoid injury to other organs. They're complete and they are transmural. We not only confirm this, but we test with pacing to make sure that the lesions are in fact effective. They're very highly effective. Depending on the scheme that one chooses and depending on the pathology, the success rate of restoring both contractility of the atria and sinus rhythm is achieved in 80 to 90% of patients. The success is independent of the duration, atrial size, and thickness, which is some of the limitation to other approaches. The addition of left atrial amputation significantly decreases the long-term incidence of stroke. And this can be done with other adjunctive cardiac procedures with no added risk. So in the future, the intention of this talk is to increase awareness of the importance of atrial fibrillation and that there are alternative important approaches to this condition. We offer at the University of Washington routine maze procedures in any patients undergoing any other cardiac surgical procedure. And we think that patients should be referred for specific surgical treatment of atrial fibrillation if they have other correctable cardiac conditions or contraindication to standard therapy. And the success of this therapy and approach suggests that in the future, this could be offered as lone therapy with people with isolated atrial fibrillation. So moreover, this particular advance is highlighting the evolution and maturation of cardiac surgery in general. We understand that as cardiac surgeons, we have to not only consider isolated problems, but we need to restore all aspects of heart function to restore normal cardiac conditions. And those are not just correcting structural disease, but restoring shape, and finally, restoring rhythm and synchrony. Thank you for your attention.
Thank you, Dr. Aldea, for your excellent presentation. I'd like to thank the audience for their participation as well, and look forward to welcoming you to another Grand Rounds for the Regional Heart Center in the near future. Thank you very much.
Thank you.